section is treatment of spondyloarthritis with special reference to current perspectives. Spondyloarthropathy, as you all know, is disease of inflammatory arthritis, predominantly axial pain with stiffness. And inflammatory means, as all of us would appreciate, the pain improves with activity but deteriorates with rest. Pain is second half of night, so patient goes to bed comfortably. Second half of night, when he or she is trying to change his posture, there is significant pain, stiffness, awakening from sleep, early morning stiffness, and may start with fleeting buttock pain. This is the most important clinical component, usually involves below 40 years of age and male preponderance. Unlike rheumatoid or lupus, predominantly female. And the most important investigation for confirmation is plain X-ray, straight X-ray pelvis and not MRI for documentation of sacroiliitis. And if there is no sacroiliitis in X-ray, so we may go for MRI, and if it shows sacroiliitis, that's not characteristically ankylosing spondylitis, but we usually nomenclature that disease as non-radiographic spondyloarthritis. Spondyloarthritis usually involves ankylosing spondylitis, that's a sine qua non, most important component. In addition, we can have IBD associated arthritis, we can have psoriatic arthritis, we can have reactive arthritis. So these are the components of spondyloarthritis, but for all practical purpose, we focus as always in terms of ankylosing spondylitis. So inflammatory back pain below the age of 40 years with a documentable sacroiliitis in X-ray pelvis, and from that point starts our management protocol. And what are the goals of treatment? First and foremost is relief from pain and stiffness, because it involves the young patient, early age below 40 years, and that's the age where the most work component involves, and he may be the only earning member of the family. So next part is restoration of function, prevent bony erosion, ankylosis of spine or development of spinal deformity. This is most important in contradistinction to rheumatoid arthritis, where erosion dominates, but in SPA, precisely in Angspon, bone proliferation in addition to erosion is another hallmark, and management of extra articular manifestations as well, like uveitis, like skin psoriasis, like IBD. So these are the things to be taken care. So what are the treatment options? First and foremost, one should not forget that physiotherapy and exercise are the most important one. By non-biologic agents, precisely the NSAID. But one should not forget that NSAID as a treatment option in ankylosing spondylitis is not to get relief of pain only, but this is acting as a disease-modifying drug, and not only taking care of erosion, inflammatory cascade, but also it takes care of bone proliferation as well. So for all practical purpose, this NSAID could be equated with TNF inhibitor in spondyloarthritis. Next comes the biologic agents and surgery, last but not the least, precisely in severe persistent pain limiting hip mobility, THR, one can go for spinal surgery in atlantoaxial dislocation. So what are the issues in terms of NSAID? First line drug, and it improves spinal pain and function. Continuous NSAID intake over 2 years slow new bone formation in the spine compared with patients with intermittent NSAID intake. So NSAID, not as a painkiller but as a disease modifying drug, can be continued even up to 2 years in young patients who do not have any associated comorbidities. Etudicoxib is usually a preferred drug, useful in the first line management, and it's being an initial drug of choice in ankylosing spondylitis. But as we were talking, GI and CVD risk profile is to be taken care before planning for NSAID. Next is glucocorticosteroids. Topical glucocorticosteroids may be used in anterior uveitis and also in situation of intra-articular lesion, intra-articular glucocorticosteroids in a selective mono or post-articular arthritis. But systemic glucocorticosteroids is usually not supported by any recommending body, which is a most important tool for the management of rheumatoid arthritis. Disease modifying drug is another part which is a most important component in the management of RA, but in spondyloarthropathy, especially ankylosing spondylitis, sulfasalazine and methotrexate not effective usually for axial disease. Sulfasalazine may be effective in peripheral joint symptoms and in recurrent uveitis. Recent data showed sulfasalazine or sulfasalazine plus methotrexate may decrease the requirement of biologic therapy by 21 to 24%. Sulfasalazine beneficial role in reactive arthritis as well. And in psoriatic arthritis, methotrexate, sulfasalazine, leflunomide has got a proven clinical efficacy. Some literature documented some sparse data of intravenous pramidronate, beneficial effect on both axial pain and function, level 3 evidence, thalidomide, beneficial effect of and spinal disease, level 3C. Extra-articular manifestation, first is uveitis, most common acute anterior uveitis patient presenting with a pain, redness, photophobia. Topical glucocorticosteroid is the mainstay of therapy. Sulfasalazine, methotrexate as we were talking, azathioprine, mycophenolate can be an alternative choice. In refractory cases, cyclosporin is a good choice. Enthesitis, heel pain, rest, orthotics, soft heel support, local NSAID and glucocorticoid injection, pamidronate, and TNF inhibitor therapy. Biologics in axial spondyloarthritis, indication of biologics in AS, a definitive diagnosis of AS is the most important prerequisites, and patient is having active disease at least for 4 weeks, and active disease being documented by sustained BASDAI of at least 4 and an expert opinion for activities being endorsed. Presence of refractory disease means failure of at least 2 NSAID during a 4-week period, or failure of intra-articular glucocorticoids, or failure of sulfasalazine in patients with peripheral arthritis. Biologics used, TNF blocker might diminish symptoms, but it is unclear whether it decreases or halts the rate of radiographic progression. Early anti-TNF therapy, effective on clinical symptoms, sufficiently suppress inflammation in long term, has a positive benefit-risk ratio. The most important component is infection, so that's to be taken care. Increased risk of TB infection is a major concern in our country. All TNF blockers showed efficacy in AS. Working group recommends infliximab and etanercept. Adalimumab clinically effective and safe, and it is subcutaneously provided, so patient can take adalimumab at their home, whereas other infliximab to be taken IV. Etanercept also can be planned subcut. Cetrelizumab pegol recently approved. Golimumab also approved for PSA and AS. Recent studies showed no increase in newborn formation with long-term anti-TNF therapy in patients with AS. Non-radiographic SPA, ABILITY-1 trial documented adalimumab in inadequate responder to NSAID, reduces disease activity, inflammatory burden, better quality of life compared with placebo. A third trial showed etanercept much superior than sulfasalazine. Etanercept showed better response than adalimumab, And adalimumab is the only approved drug for active non-radiographic SPA in Europe. Setrolizumab may be effective. What are the upcoming therapies? Targeting IL-17 is a very exciting axis modifier. Secukinumab, long-term effect in AS, extension of measure 1 trial has documented sustained efficacy in signs, symptoms, physical function in AS over 3 years, no new safety issue. ASAS 40 improvement in 61% and 50% improvement also been documented among Asian patients. ASAS 20 and ASAS 40 response around 70% and 45% through week 52. So this is a really a very great benefit which has been documented with secukinumab targeting IL-17. Future 3 trial, 4 trial, Future 5 trial. Future 3 trial in psoriatic arthritis showed 52-week efficacy and safety of secukinumab self-administered by auto-injector. Future 4 subcut with 150 mg with or without a loading dose versus placebo. Slightly more patients in low disease loading dose group achieved ACR 20 response at week 16 and 52. And Future 5 radiographic progression significantly inhibited by secukinumab. Synovitis resolution and arrest of catabolic and anabolic bone changes in PSA, 24 weeks treatment with secu. MRI synovitis PDUS signal in joint sufficiently decreased after 24 weeks, that is 6 months. MRI bone erosion, CT detected enthesiophytes, did not show any progression. Structural integrity and functional bone strength remained stable. Next part is ixekizumab in AS or radiographic axial spondyloarthritis previously untreated with biologics. Cost 5 trial, patients randomized to placebo, adalimumab, ixekizumab. ASAS 40 response at week 16, 52% in ixekizumab. In quarterly second week, fourth week, 37% in adalimumab. Each dosing regimen of ixekizumab was superior to placebo, safety profile consistent with previous indication of ixekizumab. Next part is JAK inhibitor. This is an also exciting molecule. Tortuga trial, efficacy and safety of filgotinib in AS. Filgotinib 200 mg or placebo orally once daily for 12 weeks. At week 12, mean as does change from baseline minus 1.47 in filgo group, minus 0.57 in placebo group. Filgotinib showed efficacy, safety in AS patients who have not responded to NSAID. Tofacitinib 5 and 10 mg BD per day also showed efficacy in patients with active AS. So to summarize, concept of spondyloarthropathy is changing in every aspect, and it's remarkably reversible, or rather can be halted or can be slowed. NSAID has disease modifying property. In addition, also halts new bone formation. As we are talking, TNF inhibitors unable to check radiographic progression, though recent data showed some hope. IL-23, IL-17 pathway plays a major role in differential bone changes in SPA, and targeting IL-17 may be beneficial, halting radiographic progression. Long-term data is, however, required. So there is a really remarkable switchover in the management of spondyloarthropathy, precisely AS, where we have initiated with only we allowed progression of disease around a decade back or 2 decades back, and from that point we have gradually changed and landed to the concept of taking into account the erosion, bone proliferation. Another most important part I need to address is HLA-B27 role. HLA-B27 positivity is not synonymous with ankylosing spondylitis. Patients who is having inflammatory back pain with X-ray documenting sacroiliitis, one should not go for HLA-B27. Patient is having characteristic inflammatory back pain, X-ray negative, MRI also could not document sacroiliitis, but having strong family history, in that situation one can ask for HLA-B27. If we take 100% in the society having HLA-B27, less than 5 would be having ankylosing spondylitis in future. But if we take 100 ankylosing spondylitis in the society, more than 90% would be having positive HLA-B27. So HLA-B27 as an investigational modality one should not address for screening of ANK-SPOND. So ankylosing spondylitis, young male, inflammatory back pain, X-ray documenting sacroiliitis, no need for MRI, no need for HLA-B27, asking for physiotherapy exercise followed by NSAID, waiting for 2 to 4 months, no response, plus minus peripheral arthritis, one can plan to add sulfasalazine, no response, one can plan for TNF inhibitor. But with the availability of IL-17 inhibitor, secukinumab, one is seeing very encouraging hope in the management and outcome of ankylosing spondylitis at this point. Thank you very much.